All right, so now let's move on to the proximal renal tubular acidosis, and that is the type of the RTA. And of course, first have to remember out what's the main job of the PCT or the proximal convoluted tubule in terms of the bicarbonates. So the PCT is absorbing about 80 to 90% of the filtered bicarbonate via the carbonic anhydrase. You will also learn that in the nephron transport physiology. And under the normal conditions, what happens? The PCT is incredibly efficient. But if your blood bicarbonate is normal, the PCT reclaims almost all of it, and virtually no bicarbonate appears in the urine. So in type 2 RTA, do remember that there is actually defect into the PCT's ability to reabsorb the bicarbonates. Okay, and the transporters, for example, if we do have the transporters, often like the sodium and the hydrogen ion exchangers, right, or we do have the carbonic anhydrase enzyme itself, they are impaired, they are not working properly. So what happens? The threshold for the bicarbonate reabsorption gets lowered, and bicarbonate spills into the urine, and this leads to the metabolic acidosis. And some of the key diagnostic norms that you can remember out, that what happens to the urine pH. So this is where it actually gets interesting, and it's one of the common source of the confusion. So let me just walk you through it. Imagine we do have a patient with a type 2 RTA, and their blood bicarbonate level is low, and let's say that is only and only 15 milliequiliters, right? uh, the patient is just having the bicarbonate this much lower, but their PCT, their proximal convoluted tubule, can still reabsorb the bicarbonate up to a certain reduced threshold. So when the plasma bicarbonate is below the reduced threshold, the PCT is actually able to reclaim all of that bicarbonate that is filtered. So in this situation, no bicarbonate is going to reach to the distal tubule, and the distal acidification mechanisms, for example, the alpha intercalated cells, they are still intact. So the urine can be acidified normally, and the urine pH will be less than 5.5, right? But what happens if you give this patient bicarbonate? If you raise their plasma bicarbonate, if you are now raising the plasma bicarbonate into these patients, what is going to happen out? This is the question that should come to your mind. So do remember that if you raise their plasma bicarbonate above the reduced threshold, the PCT becomes overwhelmed. The bicarbonate spills into the urine, and when bicarbonate reaches the collecting duct, it buffers the secreted hydrogen ion and raising the pH of the urine, right? And in this such a situation, the urine pH more than more than 5.5. So this is one of the actually classic pattern that we'll look up into the type 2 RTA. The urine pH, it can be less than 5.5, right, when the plasma bicarbonate is below the reduced reabsorption threshold. And in the same way, it can be more than 5.5, right, where the pH is always greater than 5.5, right, and regardless of the plasma bicarbonate. So what about the potassium? What about the potassium in this such a situation? In type 2 RTA, do remember that we also see the hypokalemia. Why? Because the increased delivery of the sodium and the water to the distal nephron. Why is that? Because the PCT is defected, right? And whenever we do have the increased delivery of the water and the sodium to the distal nephron, that is actually stimulating the aldosterone, and later on it drives actually the potassium secretion. Okay, so additionally, the bicarbonate wasting creates a negative charge in the lumen, and whenever we do have the negative charge in the lumen, that favors the potassium loss, right? That favors the potassium loss, and we face up the condition with the hypokalemia. All right, so another thing that we have to remember are the causes. That's Fanconi syndrome, one of the cause of this RTA type 2, because why is that? It is often part of the more generalized PCT defect. So you will frequently see it as a component of the Fanconi syndrome, and which we have also discussed into the nephron transport physiology following lecture. So another one, the reason, the multiple myelomas, right? Or you can also say that whenever we do have the carbonic anhydrase inhibitors, right? And these carbonic anhydrase inhibitors, these are the class of the drugs that actually include the acetylzolamides, right? Acetylzolamides, acetylzolamides, right, which is used to treat the either glaucoma, right, or either the altitude sickness. So this is why actually acetylzolamide also causes the metabolic acidosis, and it essentially induces a temporary drug-induced type 2 RTA. Do remember out this key point. And after that, you can remember it out the risk factors. That is, why does this include, or why does it actually linked with the increased risk of the hypophosphatemic rickets? Why is that? Because whenever the phosphate wasting leads, whenever we do have the phosphate loss, right, that will leads up to the bone demineralization. That will lead to the bone demineralization, right? The bone's demineralization. Mineralization. With the loss of the phosphates, for example, whenever it occurs as a part of the Fanconi syndrome, it leads to the hypophosphatemic rickets, right? And now because the phosphate wasting leads to the bone demineralization. So the type 2 RTA, you can just remember it out, defect into the proximal convoluted tubule. Whenever we do have the defect into the PCT and the ability of the PCT to reclaim or reabsorb the bicarbonates. Of course, there's going to be the variable urine pH depending on the plasma HCO levels or the bicarbonates level, leads up to the hypokalemia, often associated with the Fanconi syndrome. And